Thank you. We're going to go through a lot of different information tonight. This is the first time we've had a live vaccine that we're going to use in the elderly, and obviously there are a lot of specific challenges about what that will mean for ours. These are the disclosures. I've received research funding or funding to conduct education sessions similar to this, or travel support, including honorarium from the following companies: Novartis, GSK, Sanofi, CSL, Seqirus. If there's any vaccine company that has not supported my work that's in the audience, please feel free to get in touch. We're always happy to do more research. I'm not receiving funding for this session. The views expressed are my views and not the views of anybody else. So what we want to cover today is herpes zoster, the epidemiology of shingles, the complications of shingles, the vaccine that's now on the NIP, the program rollout, and then special considerations. And then at the end of that, we've got a series of case studies that Lisa will go through with questions so that you've got some practical experience of what you're going to be seeing soon in your practice. The varicella zoster virus is very familiar to everybody in the room. The pathogenesis in the pre-vaccine days usually started as a child was exposed to the virus through the upper respiratory tract, went through a 2 to 3 week incubation period, travelled to the regional nodes and the primary viremia, and then went out to the vesicular rash that everybody's seen, and probably doesn't see a lot of it because most parents in the audience would have a look at chickenpox in their children and go, that's chickenpox, and often not even go to their general practitioner. The sad thing about it is that it replicates in the epidermal cells, but then it goes and sits in the nerve endings and the dorsal root ganglia, and it stays there, and it reactivates in later life, leading to an infection of the nerves and the dermatome, and we get herpes zoster, which is why we're here tonight. And this is herpes zoster or shingles, a localised rash, very severe pain, vesicular for 3 to 5 days, then it forms a crusting process. It takes 2 to 4 weeks for the rash itself to heal, often accompanied by systemic symptoms, and essentially the reactivation of the latent varicella zoster virus that they had when they were children. The incidence is not unknown in adults younger than 50, but it markedly increases with each decade after the age of 50. It's usually unilateral, painful, and has a dermatonal distribution. More than 90% of individuals over 50 will have an acute pain associated with the rash when they get it, and some of them are particularly unlucky because they get it in dermatomes that produce very significant consequences, over and above the pain issue that we're going to talk about. So zoster itself, the complications are often site-specific. Obviously, if you have zoster ophthalmicus, there is a small chance that you'll actually go blind as part of it. In the immunocompromised, and this will be an issue when we give live vaccines, disseminated shingles is possible. But the main thing that we really want to talk about tonight is the issue of postherpetic neuralgia. And I don't know whether everybody in the room's had a relative. I've had a father and a sister who got zoster and had postherpetic neuralgia. It is just a nasty, nasty disease for people to put up with. By definition, it's pain persisting for more than 3 months. And there's a number of risk factors, although they're not modifiable. The worse the rash in the acute phase, the higher the chance of PHN. The higher the age of the patient, the higher the chance of PHN. And this has a substantial impact on the quality of life. And so in the same way that elderly who get influenza don't return to the same quality of life in the frailty scale, people who get herpes zoster often decrease in their activities of daily living capacity. It can be refractory to treatment. The management is complex and pretty well unsatisfactory in most cases. And antivirals, simple and complex analgesics are all used at different times. And this graph on the side is the number needed to treat with the common pain therapies to obtain 50% pain relief in one patient. And you can see that different things, including opioids, have somewhere between a 2.5 to 4.5 NNT. So if you treat 4.5 people with with one of these medications, that's what it takes to get one of those 4.5 to actually have 50% symptom relief from pain. So this is not something that we deal with particularly well as a medical community. There are some treatment options early to try and minimise the severity and duration. Antivirals is certainly something that does work if presented early in the onset of the rash and used early on. It doesn't, however, according to a recent Cochrane review, decrease the chance of PHN. So if they're going to get postherpetic neuralgia, they'll get it no matter what you do. But what it does do is duration the acute episode there. A range of analgesics have been tried, simple analgesics like paracetamol, opioids, tricyclic antidepressants have all been used, and there's supportive care processes to use cool compresses, bathe the lesions and so on. And regular monitoring by a GP is important during this process. The impact on the quality of life is right across the 4 domains. There are physical, psychological, functional and social impacts of getting zoster in the elderly. The greater the pain, the greater the interference with daily activities, and some people, similar to influenza infections, experience a permanent loss of independence as part of the process that they're going through, and that was a French study that documented the decrease in the health domains for these people. This is the clinical frailty scale. About 10 years ago I was in that number 2, no active disease symptoms but less fit than most 50-year-olds. Sadly I'm now one of those ones with a walking stick. I'm hoping my private insurance period of waiting decreases soon so I can get my hip replaced. So I'm somewhere around the 4 or 5 stage. My wife would say I'm probably closer to 7. Either way, I'm pretty sure that I don't want to get zoster myself. The good news is that about 3 years ago, my wife and I swapped the zoster vaccine with each other for Valentine's Day. And so we've already had our dose of this when we're overseas in North America, and I can't think of a more romantic gift for your spouse than to give them, something long-lasting, unlike a bunch of flowers or something which is gone. The last group I told that to wanted to know whether I was actually still married. Yesterday we had our 30th wedding anniversary, so there you go. Zoster vaccine works. This is the issue of immunosenescence and zoster and why the vaccine works in this particular setting, and why we're worried about the fact that we're vaccinating all our children and we're getting less supportive boosting that we used to have. So in the old days when you were young, you got varicella, you had a big increase in the T-cell response that stayed with you. And over time, those little red bumps, the triangles in that, are exposure to the varicella that just circulate in the community. You didn't get chickenpox again, but what you did get was a boost in your T-cells. And that happened on a fairly regular basis, and it's not going to happen now, as you'll see in a graph coming up about the decrease in zoster itself, in chickenpox. And over a period of time you get old and your T-cells start to decline, and when you get below a zoster threshold, that what happens is that you are then prone to getting herpes zoster. The virus comes back out from the nerve roots and gives you shingles and gives you all the complications. And so what we're aiming to do in the dotted blue line is produce a response from zoster vaccination that increases your T-cell immunity again over and above the decline that you've had with age. So who gets it? Everybody gets it, essentially. I mean, we're way past the age when we were vaccinated with varicella when we were young. The lifetime risk of having been exposed to chickenpox when we were young is something like 97%. And so, you'll look at our protocols for what you should be doing. At no stage are we saying, hey, go out there and check everybody's, varicella levels before you give them Zostavax, because in the end we're just assuming that everybody's had chickenpox if they're over the age of 35. If you are over the age of 35 and you were part of the group that was not vaccinated when you were younger, your lifetime risk of zoster is around about 20%, so 1 in 5 will get it. 70% are over the age of 50. Recurrences are actually quite rare once you've had it, But the numbers are really astonishing, and I'm sure you've all seen them in your practices. 150,000 new cases annually in Australia of zoster, and 1 to 3% of those are hospitalised. And the severe part of this process is that 15% of those will go on to develop postherpetic neuralgia, and so they're having 90 days plus of severe pain associated with the shingles itself. And that rate goes up. Once you get to the 80-year stage, about 1 in 4 will develop postherpetic neuralgia. And about 1/3 of those 1 to 3% who are hospitalised are actually hospitalised with postherpetic neuralgia. And this is one of the challenges that we're going to face in clinical practice as we introduce the vaccine. So we know 97% of adults have latent varicella zoster virus in their nerves. When they did a recent study looking at adults aged 60 years and above, only 4% of adults believe that they are at high risk of developing shingles. And so if only 1 of 25 of your elderly patients think they're going to get shingles, they're not going to be beating down your door on the 1st of November to say, I want this vaccine that's just become available. So we're going to need to recruit to the vaccine programs, to the national program, and to the people who should have it that aren't covered at the moment, because shingles is on the rise in this group, and yet it's not something that the average elderly are aware of. These are a couple of slides about what's been happening with shingles over and above the issue that we've got people getting older. So shingles is on the rise not just because the population is ageing, but because the age-specific incidence is increasing as well. And so if you look at this, this is the antiviral prescription rates for herpes zoster in general practice, and you can see over time each of those lines, which is a different age group, is on the increase. So it's not we're getting old, we're getting more shingles. And these are ED data from New South Wales, both the non-admitted and the admitted. It's not as dramatic in the admitted group, but you can see again age-specific ED attendances for zoster have been steadily increasing for a period of time, and particularly over the last 5 to 10 years. So this is something that is not only very common, but is also going up. And these data are the general practice encounters, and you can see that there's now a reversal of what's been happening. We used to see about as much shingles as we did chickenpox in practices. Now that we've introduced a vaccine for chickenpox itself, the numbers of cases of chickenpox that you're seeing in your clinics is clearly going down. I mean, this is not a perfect vaccine in the young, but certainly it's had an impact on how much chickenpox there is out there. At the same time, the green bars going up are showing that at the same time as chickenpox is decreasing, shingles itself is increasing in general practice. And this is important in our decisions as to who to vaccinate or not. These are 3 bar graphs. The black and grey bar graphs are 2 different estimates that we've had for shingles and the incidence per 1,000 people in different age groups, and you can see that as you increase in age, the amount of shingles goes up. And the white bar, that's a little bit harder to see because it really only gets big once you get to 50 to 59, is the proportion of those who actually have postherpetic neuralgia. So that increases substantially as you get older as well. So serious disease, significant numbers, what can we do about it? And so the rationale for the development of a zoster vaccine was based on 2 issues. Firstly, it's a nasty disease and there's a lot of it. And secondly, there isn't a change in antibody as you get older, but the graph that I showed you earlier shows that the T-cell responses to zoster decrease as you age. And so there was 2 hypotheses that led to the development of vaccine. Firstly, that the fall in T-cell responses meant that if we had a vaccine, we could actually clinically reactivate. We could prevent clinical reactivation by increasing the T-cells, and that then increasing the T-cells would lead to either prevention or at least attenuating herpes zoster. And Zostavax does both of those, so moving forward. There was a series of pilot studies done by Merck back in the day, and they showed that T-cell responses to a VZV could be boosted with a live attenuated strain. They suggested that the booster effect was increased for at least 6 years, and they also suggest that there would be attenuation of breakthrough zoster. So if it didn't work in everybody, those people who did get zoster afterwards would have a less severe case of zoster and would probably be more effective in preventing postherpetic neuralgia than it would be in preventing zoster itself. And so this is the vaccine that is about to come onto the NIP. It's a live vaccine. It's exactly the same as the chickenpox vaccine. The difference is it has 14 times more antigen, more attenuated virus than in the chickenpox vaccine. It's licensed in Australia over 50 years, and it's indicated officially for the prevention of shingles in those 50 years and above, and the prevention of postherpetic neuralgia and the reduction of acute pain. And we'll go through the program later on, but it's actually going to be free from the 1st of November for everybody from 70 to 79 years of age. It is a single dose at this point of time. It's a subcutaneous vaccine. It stays in your fridge. It's reconstituted before using it. And if you don't use it within 30 minutes, throw it away. It's a great improvement. Some of you will remember the version we had a decade ago that used to be frozen and kept in your freezer and got almost zero use because of the challenges of actually having a frozen product in general practice. So does this stuff work now that we're finally going to get it? The pivotal efficacy trial was officially the shingles prevention study, conducted in almost 40,000 people aged 60 and over, standard phase 3 trial, randomised double-blind, placebo-controlled. Patients either got vaccine or placebo and then followed up for about 3 years afterwards. And the main endpoint was the burden of illness due to shingles, and the secondary endpoint was the incidence of postherpetic neuralgia. And so overall, for people 60 years and above, the Zostavax decreased the incidence of shingles by about 51%. So just over half the people over the age of 60 having had a Zostavax single dose ended up not getting it compared to those that got the placebo. And happily, this was even more significant in reducing the incidence of postherpetic neuralgia. So 2/3 of people who got Zostavax were protected compared to placebo in getting postherpetic neuralgia. So some of those 49% that still got shingles missed out on getting the postherpetic neuralgia because they'd been vaccinated. And people say to me, well, you know, it's 67% effective. It's the same argument they have about, I don't want flu vaccine, it only works in 60% of times. If you're not vaccinated, it works 0% of the time. PCV7, when we introduced Prevnar 7, worked 60% of the time because that was all the coverage we got from those 7 serotypes. Gardasil we give to as many of our children as we can, and it works about 65% of the time because we're not covering all the serotypes that cause cervical cancer. So, you know, the days when we make a measles vaccine and everybody's good for life are gone. And, you know, what we're looking at is incremental improvements in what we're seeing in disease burden. And certainly this meets the same sort of criteria of many of the recent vaccines. Meningococcus B, again, is very similar. You know, it depends on the strains, the match studies in different countries, but, you know, it probably works in 65 to 80% depending on where you are. I have a problem with old people. Their white cells don't work very well. You know, if they're like me, their hips don't work very well, their kidneys don't work well in some cases. What definitely happens is the older you get, the less your CD4 cells and your killer cells and everything work. And it's why my flu vaccines almost never work in my nursing homes, and it's why Zostavax, as you increase in age, decreases in efficacy. So 70%, 50 to 59, still 60 to 65%, but then after 70, probably closer to 40%. The good news is that despite the fact that none of our vaccines are great when you get older, this protects up to about 79 to the same extent against postherpetic neuralgia. So you don't see the same waning in its protection against severe pain, chronic severe pain, as you do in its protection against zoster itself. So there's some data there which I won't go through about how long it lasts, There's really good data that says after 5 years this still works pretty well. There's also data that said it probably works out to about 8 to 10 years of age, but it's starting to decline. At this point, we don't know how long it will last, and we do not at this point have a recommendation for a booster. But obviously we're monitoring the situation, not just in Australia but in other countries, and we will be looking at providing a booster if necessary. So overall, from the shingle prevention study, Zostavax significantly altered the natural history of zoster. It prevents zoster in the younger groups. It prevents or attenuates zoster in older groups. It is efficacious and safety in several large post-marketing studies, and in the extension study in the 50 to 59-year-olds. The good news for my wife is that this will continue to protect her for some time to come. So, to give my voice a break, the Australian Government has announced a free Zostavax program commencing in November of 2016. It'll be funded for people turning 70 years of age, and for the next 5 years there's a catch-up program for all people between the ages of 71 and 79. So this is very similar to the program introduced in the United Kingdom recently. The decision as to who to fund for vaccine was based on a combination of factors: how common the disease was in a particular age group, how effective the vaccine was in that particular age group, and what that meant in different levels. So we know for people between the ages of 60 and 69, they actually have more effective response to the vaccine, but they have significantly less disease. And similarly, it's not funded for those over the age of 80, because even though they have more severe disease, we know the vaccine doesn't work as well. And so that was the reason the government decided to fund it for that 10-year cohort between the ages of 70 and 79 years. And so that's the group who's going to get vaccine. You're going to see a whole lot of people who aren't 70 to 79, and we need to make decisions about what happens to them. This is very important for general practitioners to understand. People outside the age range can access vaccine. Vaccine is actually licensed in Australia from the age of 50 years onwards, and our specialist advisory bodies recommend that vaccine be offered to people over the age of 60 years. People between the ages of 60 and 69 years will have to pay for the vaccine, but the vaccine works very well in that group, and even though they have a little less disease than people between 70 and 79, we have a vaccine that works in that group and it will be effective. So we should be offering them protection. What we do know is that we will need to seek them out as part of the program. A recent survey found that only 4% of people over the age of 60 believe that they're at risk of zoster. And so we need to be using all of our opportunities in general practice to raise the issue with our patients. If they present for an influenza vaccine, if they present for a brow screen, perhaps they're coming for their checkup that you get at 75 years of age, all of those are opportunities for general practitioners to talk to them and say, we've got a new vaccine, it protects against a very nasty disease. You can either have it for free or you should consider paying for it if you're outside the age range. While it's licensed for people between 50 and 59 years, we don't recommend that they be giving it that early. They'll need too many boosters possibly. However, occasionally, for other reasons, we may offer it in that group. If someone between the ages of 50 and 59 is about to start on immune modulating therapy that would prevent them actually having the vaccine later, then you may want to consider it. But it would be uncommon for us to offer vaccine prior to the age of 60 years. So that's the program in Australia, and that's the recommendations for people outside the funded program and what we should be doing. This is a summary of what's happened elsewhere. In the US, the ACOP recommendation was to actually vaccinate everybody over the age of 60, not over the age of 70. They're increasing their coverage of that age range over time. Their overall uptake is now over 20% and continues to increase. And they've used 16 million doses, which is good because it gives us a basis for a lot of the phase 4 post-marketing activity as to the safety and effectiveness. The UK in September 2013 funded exactly the same program that we have here, 70 to 79 with a catch-up cohort. In Canada, some vaccine is used in the provinces, but it's not part of the schedule. Canada is a strange country, having worked there for 6 years. Each state has their own program. So eventually one state might introduce Zostavax as part of it, but it doesn't mean anybody else will have. You know, Alberta gives males HPV, but doesn't give children Zostavax, rotavirus vaccine. There's this little bit on the east coast called Quebec, who, as a matter of principle, do exact opposite of what everybody else in Canada is, because they're French. And so, you know, they've got some, but they don't use a lot of it. And of course, in Australia, it's been available on the private market for a long period of time. We've got some Securus people in the audience. They might know how much of this has been used, but I suspect a very, very small percentage of Australians have done it. Is this vaccine safe? So there have been lots and lots of clinical trials, and in fact there's been a lot of post-marketing work as well. So the most common adverse events are the same sort of stuff we see with most vaccines: redness, pain, tenderness and swelling at the site. There's been a very good overall safety profile. We don't see a lot of issues with this, with one proviso. The shingles prevention study had low rates of rash, injection site reaction, no serious event signal compared to placebo, and no safety signals from post-marketing experience at this particular point. But like every clinical trial, when they're assessing vaccines, they don't go and pick the unhealthiest, worst batch of people out there they can get and give them vaccine and then see whether or not, you know, they can license something at the end of it. So we had a clinical trial which was essentially well population people. Our real population is going to have a whole lot of people who are somewhat immunocompromised, and we have a live attenuated vaccine with potential for systemic replication. If you inadvertently give it to somebody who is immunocompromised, then we're going to see some issues with some of these. So the Australians are going to roll out a safety surveillance plan in conjunction with the rollout of the vaccine starting next month. And there are a number of arms of this, and the one that we'll be heavily involved with on the Gold Coast is a thing called SmartVax. I don't know how many GPs here are currently using SmartVax as part of the monitoring of their vaccines, but we are going to roll out an additional 10 practices in the next 12 months as part of our safety monitoring on the coast with the PHU Primary Health Network collaboration. This sends a text directly from your software to anybody who has a vaccine. So somebody gets a shingles vaccine, 3 days later they'll get a text saying, did you have a reaction? If you go yes, it sends you another text saying, did you see a doctor? And if you've said yes to either question, it'll send you a thing saying what was the reaction, and you'll answer a short questionnaire. We collect all that data, and it'll give us very good data overall as we move forward, because instead of them having to come to you or go to the ED and we don't even know about it, you will be doing active surveillance via these systems. And in the end, you know, you'll get some feedback about what's been happening with this particular process, but we think it's an important part of monitoring, you know, what's a new era for us, a live vaccine in the very elderly. So far, the post-licensure safety studies, Kaiser Permanente and the US system have essentially shown that there was an increase in the younger groups in medically attended reactions, but it was largely local tenderness. No serious side effects after a second dose, and no serious side effects if people with a history of zoster have had vaccine. I can't remember whether I put in a slide about that, so let me just speak about that now. If someone has had zoster or has zoster at the time, they can be vaccinated and will get benefit. But this is a live vaccine that we're overriding their current immune system to boost their T cells. If they've got zoster, they're boosting their T cells. And so at the time that they have zoster is not the time to give them a vaccine. And while there's no fixed recommendation, the general consensus is if they've had zoster, wait 12 months from the cessation of symptoms before you actually give them a dose of Zostavax itself. Okay, confusion out there between some different studies about this question, and the PI for Zostavax is probably not consistent with what Atagi and the rest of us believe. You can give zoster with anything else that we normally give the elderly. If they are due for a flu vaccine, give them both. We have no increase in reactions and both vaccines work. If they're due for pneumococcal polysaccharide vaccine, give them both. There was a small study originally from Peter McIntyre's group that said that if you gave them together, you got a decreased immune response. And that led to the recommendation in some places saying don't give pneumococcal vaccine with zoster. Since then, there's been a study instead of 400 or 14,000 people which shows that in fact this works just as well if they're given simultaneously. So give both vaccines and give all vaccines at the same time. It's the same if you're giving a pertussis boosters. Both will work. Very rarely you'll get somebody who needs another live vaccine. They're going to a yellow fever country or something. Give them at the same time. And if you don't give them at the same time, then you need to separate them by at least a month to make sure that they work. But that's the same with all concomitant live vaccine administration. We're going to deal with some of the contraindications in a bit more detail in some of the case studies, but it's a live vaccine. You don't give it if they've got hypersensitivity to some of the vaccine components, if they've had a reaction to neomycin, which is in there, if they have any immunodeficiency state, and there's a list there and the list could go on. If they're on immunosuppressant because they've got solid organ transplants, if they're on a malignancy therapy, even if they're on anti-TNF therapy, although there's some debate in the literature about that, don't give Zostavax. The immunosuppressive therapy, there are essentially a group of drugs that we can use this with. If they're on some of the anti-rheumatic drugs, methotrexate, any of those particular groups, azathioprine, mercaptopurine, at certain doses you can give the vaccine, at certain doses you can't give the vaccine. They're all covered really well in an MD briefcase that we've put together between the PHN, the PHU and Securus. And I'm going to refer to that at the end of these talks, but certain doses, methotrexate at less than 4 milligrams per kilogram per week and so on. I'm not expecting people will remember those, but they are in your cheat sheet that you've got in front of you, the laminated sheet. The main issue with this is we don't want to look at everybody who's on one of these drugs because there's just lots and lots of them on this stuff nowadays and say you can't have vaccine. You know, we want to try and vaccinate as many people as possible. If you have any doubts, talk to the public health unit, talk to their treating specialist and say, we really want to vaccinate, is this a good time, can we do it, what are the indications? So don't give up on all of our people on immunosuppressives. Certain doses of prednisolone work, certain doses don't. We can stop drugs, we can start drugs later. We want to try and get people protected. So if you have any doubts, seek specialist advice, look at the latest version of the handbook and talk to the public health unit. So, does vaccine present zoster recurrences? We don't know, it's too early. If you accidentally give the vaccine to someone who's on immunosuppressives, seek specialist advice, monitor them, they may need antiviral therapy and you follow them in the same way as normal and contact EVANT as part of the response. If your vaccinated patient still gets zoster, they'll probably have an attenuated condition and you just manage them as you normally would. This is an important process, although it's not working very well. It's supposed to start working a week ago. It's down most of the day. The Australian Childhood Immunisation Register, which every public health physician loves and every GP thinks is a waste of space and pays them $3 and blah, 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 is now going to be the Australian Immunisation Register. So officially as of last week, it is now capturing all vaccines administered right through life. And so when you put Zostavax into your program, it will be capturing it as well as capturing your paediatric doses. And it is improving its functionality over the course of the next 12 months to provide increased benefits for all us vaccine providers. It'll improve the data capture, enable us to get better understanding of coverage, and give you a better access to reports that you have trouble getting properly at the moment. It also means that we'll be able to identify areas of low coverage, although on the Gold Coast that's not really very difficult. We have astonishingly good coverage, probably 95% everywhere, except in some place that's called Mount Tambourine. I've been trying to move it to South Brisbane because I don't want those coverages. 1% of our population, 40% of our pertussis cases. We're working hard with the PHN and the Northern Rivers vaccine supporters to change that, but they just don't believe. And at the moment, the council is resistant to my suggestion that we put a fence at the bottom of the hill, and that we just let them all stay up there if that's the way they're going to behave. So the AIR is really important for Zostavax. We may need to give a booster dose. If we want to give a booster dose, we want to know who had the doses in the first place. So please register the doses you give on the AIR. If we decide we want to boost a dose, all that information is going to be available to you to press a button and say, here's 150 old people I need to send a note to saying, come back and have your next dose. Okay, we'll probably take questions at the end instead of right now, but what I'm going to do is stop and hand over to Lisa Beecham, and she's going to take you through a series of case studies to give you examples of the sorts of things we'll see.